better, but every year we tell that and it is still increasing. So I think the interest is really growing. The countries, the attendees come from 5 top countries we can call, and interestingly, the top country remains the US. So it's the largest European Congress, but it's very well attended by global attendees. And the US is very present in speakers you have seen, but also in terms of attendees. French colleagues, Spanish, British, and German colleagues are the most prominent nations represented. In terms of numbers, you remember we had 55 LBAs. And 7 presidential abstracts, which I think were extremely successful and really got a lot of interest across diseases. And we had 1,599 top quality posters and abstracts also being presented and discussed. In terms of publication, because it has become a metric of a Congress to know if the papers are simultaneously or shortly after published. So simultaneously, we had 4 New England Journal of Medicine, 2 Lancet Oncology, and 3 Annals of Oncology. But you also know that in ESMO, what probably makes a success, and also is a nightmare of our press office, is that we accept very, very late abstracts. If some data of interest come 2 weeks before the meeting, we make our best to make this happen in the meeting. Which means, of course, that it's a bit difficult to give you all the material in time, but it's also impossible for the authors to have it published in the same time of the meeting. So if I tell that is some of the data which have been presented here. I'm speaking about the renal cell carcinoma data. I'm speaking about the FLAURA trial in lung. I'm speaking about many of these trials will appear in big journals, but maybe 1 month after the meeting. So there are 4 New England, but there are probably 3 or 4 to come out of this meeting afterwards. We will not, because of the time frame, we will not always be able to have the front page of the paper being the last slide of the presentation, but it doesn't change so much. I think the most important thing is to give the information to the community. For example, for the renal cell carcinoma, the OS data came 48 hours before the meeting. So it's something, I mean, we have to have it in the meeting, but that just means we can't give you the publication in time. So take-home messages was probably the heading of this meeting, which was integrating science into oncology for a better patient outcome. And some very important, I must say, priorities for ESMO have been conducted and repeated through the whole meeting. And I'd like just to summarize them with you today, because it's also going to be for the next 2, 4, and 6 years our main priorities. I think Fortunato at the faculty dinners told that health is a basic human right. And by telling that, he was willing to emphasize the fact that ESMO has become increasingly involved in politics, in public policy in general, and in particular in collaboration with WHO. You've seen some of the big announcements with WHO, with EMA, and with the EU, in order to be able to manage and optimize, in general, policy around cancer and also cancer care. And the priority is also described by the sustainability of cancer care. And this has been well developed in this meeting. You have been seeing our new tool, our updated tool of magnitude of clinical benefit scale, the version 1.1, which allows us to measure and prioritize what we think are the cancer medicine which must be made available for patients. So it's very important for us to have this scale, but also our continuous discussion and conversation with authorities about cost. For example, the biosimilars is a good example to tell some concrete things that ESMO can do as a member-based society. More than this, we had, I was amazed, I went to 2 sessions from the advocacy track, but also all the sessions about patient tracks and survivors were incredibly attended, but not only by, for example, for the advocacy tracks, there were 4 times more people than the registered advocates. So it means that doctors go there. I mean, physicians, nurses, researchers. So it's very interesting to see that this becomes a priority to exchange around optimal cancer care. But more than that, and here I will give you the word, not only exchange about optimal cancer care from the time someone is is suffering from cancer, but from this meeting, we went back to the lab asking why and how can we better manage cancer care by having EACR, the European Association for Cancer Research, being associated with this meeting, trying to understand how we can improve cancer care by understanding more deeply what's happening in cancer and in treatment and all the paradigms around this. And I was also surprised to see that the first session about application of mice models to cancer research, the room was full packed. So it was kind of a bet, and people were attending the session because they're interested in that. And I would like you to evoke this collaboration.
Yes. Okay, so as I think you probably all know, I'm not an MD, I'm a PhD, so I don't treat patients. I run a cancer institute, Cancer Research UK Manchester Institute, which is in essence a basic science institute. But at the end of the day, what this is all about is patient care. And we were very excited when we first came up with the idea of partnering with ESMO, the European Association of Cancer Research, because really the basic research is what drives the new discoveries. Now, of course, we have fantastic links to the clinic, and increasingly you see basic research institutes such as mine becoming engaged with the clinicians who are actually treating the patients. So, you know, for example, in my own weekly lab meetings, which are discussing the science, we have 7 clinicians in a group of 30 who come and discuss. And it's that discussion that has to happen. And at this meeting, that's exactly what's happened. And Solange is right. You know, as a basic researcher, I cannot not be interested in what the advocacy groups are saying. So I went to those sessions, and I cannot not be interested in what the clinicians are saying. So I went to the large announcements of these fantastic practice-changing clinical trials which were announced at this. As Solange says, data coming in literally 2 days before the talk, describing how this trial will change practice, and then integrating that with the basic and translational research. And what we saw was the rooms where the EACR was more involved in organizing those sessions with the emphasis on basic and translational research. They were packed with clinicians who now want to understand the biology and the underlying biology of what we're trying to do. And so I think more than anything what this meeting has shown is that the basic researchers are obliged to start directing their scientific questions towards questions that the clinicians need the answers to. And on the other side, the clinicians need to benefit from the most recent basic discoveries to ensure that their patients get the best care that they can. And I think that's the important point I'd like to make, is that the clinicians need to get the best basic science into their clinics to improve patient care. And the scientists need to be asking questions that are clinically relevant. And I think we saw that at this meeting. And so European Association are not only proud but delighted with this meeting. And we're proud to be part of it. We're delighted with the outcome. And so we need to keep this discussion going between our members and ESMO members to ensure that patient care is improved.
Thank you. Anything I forgot to say in terms of number, Vanessa? Did I say we got through? Any question from you about whatever, science or ESMO or ESR? Yes.
You can use this microphone, maybe. Okay. Sylvie Lapostole from Agence de Presse Médicale in Paris. I was not able to go to the session about biosimilars. Could you sum up the message? Or
yes, yesterday? About the presidential in melanoma?
No, the biosimilars.
Ah, the biosimilars, yeah.
Because there is a debate, and we see lots of studies at the moment, but yeah. I don't know if the clinicians are ready to go or not.
On biosimilars. It's an interesting topic. I invite you because it's a topic we have been dealing with since maybe a year in terms of priority, right? In these considerations about sustainable care. There are many kind of, ESMO cannot change the national regulations, but you can act at a higher level trying to create some changes, introduce some changes in the health systems in general in order to help the sustainability of cancer care. One is the magnitude of clinical benefit scale, for example, because you can, in a broad manner, try to influence the way decisions are made. Biosimilar is another topic in which you can imagine to potentially ensure some more sustainability by offering drugs which are as efficient as the original, but with a cost which can be strongly lower, minimized. The main problem with biosimilar is to make sure that when you decide to offer something which has a lower cost, the quality and the impact in terms of clinical outcomes will be the same. That's why since 1 year we've been working on, and we made a position paper I invite you to go through. It's in the ESMO Open. We have been dealing with the discussion about favoring or supporting the existence of biosimilar because they're important for sustainability, but to really be able to draw what are the conditions in which biosimilar must be made available. When I say conditions, it's at the time being, the priority is really to emphasize how every step in the production and commercialization of such agents must be controlled. All the manufacturing process and the description of the production and how the biosimilars are brought into the market are very controlled steps. And the only thing that ESMO can do is supporting that these controls are systematically performed and documented in order that biosimilars are made available, but do not betray what we would like as being the best cancer care for our patients. So there are all a series of conditions, but it's very practical issues that we might help to support the control of in the future by quoting them, by potentially having some checklist about every kind of biosimilar to be sure that they at least fulfill the requirements to go on the market. But we are strongly positive for this kind of initiatives because without having this kind of opportunities, we'll not be able to sustain, or many countries will not be able to continue to give optimal cancer care with a very highly costly drug coming into the market. Any comment on that?
No, I mean, obviously, again, you know, back at the, you know, the sort of cold face of the basic research, the process of developing the biosimilars becomes essentially a technical challenge once you know what you need to make. And increasingly you see this not just through the research organizations, but also through the small biotech companies that spring up. And I think, you know, we need to encourage the European biotech sector to take on these challenges. We need to encourage national governments, maybe the European Union to fund this activity, because it's incredibly important not only for the economy, but as Solange says, for the patients to have access to this. So it really does take it all the way back to how the production of these is funded, and, you know, tax relief perhaps for startup biotech companies. I'd encourage national countries to consider, the national governments to consider that.
Robin Davison from EP Vantage. So I'm interested in your press release on practice-changing data. I actually myself attempted to summarize this as well. And, well, obviously, one of them was a somewhat, well, I felt a controversial choice here, and I wondered if you might perhaps expand on it, because I was applying the sort of test. Does a doctor who's seen this data go away and consider making a change in their prescribing choice based on this data? And that was the Pacific study. I felt the commentary was such, it was very, very interesting data, but potentially too early to make that change yet. I mean, I could conceive the concept is absolutely practice changing, but I wondered if you had any observations on that.
Well, I am one of the specialists who probably state that it's practice changing. I even support the process to the regulatory authorities in order to make this available. So I think I will tell you why I think it's practice changing. But first of all, I will tell you why I find it extremely exciting. It's the numbers. You've been seeing the impact of immunotherapy in lung cancer. We all know that it improves survival when you use immunotherapy in the palliative setting, with some months of improvement, right? If you go for unselected non-small cell lung cancer patients, you can hope for a 3 to 5 month improvement in survival, right? Remember, hardly can observe PFS, progression-free survival difference, because the shape of the curve in immunotherapy make the separation occurring late, meaning that the progression-free survival is probably an observation which come a little bit too early to really be able to detect the real difference with the standard treatment. So overall survival is the best endpoint to observe because it's come a bit later, and it might also reflect some long-term benefit of immunotherapy across subsequent lines of treatment. So what is interesting in Pacific is you are in stage 3, a curative setting, and you don't have the survival data now. You look at this bad parameter, which is PFS. And in this setting, you find an increase in PFS of 10 months by giving durvalumab versus placebo. In terms of magnitude, it's not only unexpected, it's extremely important. I mean, it's a huge magnitude of benefit. When you were writing the magnitude of clinical benefit scale, we wrote in the little table in the beginning that I would say an important increase in PFS is considered as a surrogate of quality of life. Because if you spend 10 months of your life under durvalumab, which is not toxic, without a relapse, not experiences a disease recurrence, this will improve your quality of life. So for me, 10 months PFS after a radiochemotherapy, which is a difficult treatment, it's already improving the quality of life of patients. I'm quite convinced that some survival benefit will be observed. I understand your note because, your comment, because we still don't have the survival data. I understand that, I'm quite convinced some survival benefit will be observed. But even if it were not the case, if you have patients who give 60-grade chemotherapy and have 10 months delay, at least 10 months delay in progression, to me it's already an endpoint which deserves introduction on the treatment. Because remember, it's not only reducing the rate of local progression, it reduces half, 2 times, the number of brain metastases or bone metastases or liver metastases of skin metastases observable in these patients. So all this to me, this 10 months is about the quality of life of this patient. 10 months is really huge. In terms of science, the exciting thing is you give radiotherapy and chemotherapy, you give durvalumab, and suddenly you have twice less brain mets. You have proven that abscopal effect exists. Yep. You have proven that you can vaccine a patient and just deblock the T8 cells to go, the CD8 to go into the tumor and kill the cancer cells. So it's just a proof of concept. And the whole noble side of this trial is the placebo control side. And for the anecdote, we will learn a lot about this trial because, for example, in the placebo arm, if you look at the adverse events, and if you look at immune-related adverse events, because the investigator classifies as the adverse event, when you look at the immune-related adverse events, in the placebo arm, 8% of the patients were affected by immune-related adverse events, which means that we still can't, as clinicians, be very good in trying to understand what's happening in patients when we give immunotherapy. Because we consider sometimes that usual side effects or usual fatigue or usual troubles that you could observe in the patient way could be immune-related and are not. So it's very interesting. We learned a lot of things about it. Mm-hmm. So that's my take on of Pacific. Apart from the fact that in 20 years we have been increasing chemo, radio, add cetuximab, add vaccine with no improvement in survival in stage 3. So it's also about the history of 1,000, I would say probably 20,000 patients being randomized in clinical trials without any survival improvement or even PFS improvement to date. Any comment on that?
Yeah. No, I mean, I think it's really exciting data. And what we need to understand is that we are making progress, and an improvement of 10 months, when you look at it over a 5-year period, suddenly becomes significant because that's an improvement over and above what's been seen. And if you take melanoma as a paradigm, when I moved to Manchester 5 years ago, the average survival of a melanoma patient in Manchester was about 6 to 9 months. Now it's somewhere between 2.5 years. And that's in a very short period. We've seen this amazing improvement, and that's driven partly by the targeted therapies, but also importantly by the immunotherapy. And also, patients never used to get cured in melanoma. Now we do see a small proportion of patients getting cured. And so I think you have to look at the long-term benefits. And by taking that and going back and understanding the patients and understanding the underlying biology, we will be able to drive this into much more effective not only treatments, eventually into cures. And that's what I'm excited about, because, you know, we have anecdotes of patients in the melanoma field, and they will come out, it's a bit too early for lung cancer, but they are starting to come out, where, you know, I was discussing it with somebody last night. A patient, 25 years old, metastatic malignant melanoma with brain mets, had one of the very early, had ipilimumab. She is now 7 years past that. She was one of the first patients to receive it. She's had 2 children, and she is effectively cured. I mean, we can be very confident that that patient is cured, and she's getting on with her life. And so I think that's what excites me, and I think we need to understand the whole underlying biology of immunotherapy in order to be able to use it properly and learn how to stratify the patients. But we will see these fundamental changes. They are really practice-changing approaches to treating our patients.
I wanted to sort of make another, was more of an observation, perhaps implied even criticism, which relates to Checkmate 214. And I appreciate that there were special circumstances about that study that meant that it was, you know, the data was very fresh. But I mean, given you put out a press release about the quality of reporting in the public domain, it seemed to me that the data that was presented at the press conference and the data that was presented later in the afternoon were quite different. And you know, the journalists here would form the impression that it was a highly positive study, and yet when the more full data were presented, in fact, even the hazard ratio wasn't presented to us, the evidence was that the combination wasn't any more effective in the PD-L1 negatives, and it was detrimental in the good risk patients. Now, that's quite a different story to saying this is a universally positive study. Now, I appreciate it's still practice changing, but you know, I don't know whether you have a comment about that. I think it was unusual to me that the press release, the press conference was given a sort of partial set of data that allowed them to form an impression which was more favourable than might be the case. You know, especially when there's another study in renal cancer, the Cabazon study, yes, which is being presented, and it to me it looks questionable, that decision.
The question is more about the format of communication between the press conference and the plenary session, right? It's
yeah.
more about the yeah. content, right? So I agree with you. It took to us at the press office lots of discussion and effort. One of the explanations for this kind of strange type of communication, or unusual differences, is because of the last minute setting, right? We got to learn the data, myself the night before. This is the style of the presenters. So here you have to understand that Bernard Escudier, who is the first author of this paper, wanted to keep the whole set of kind of excitement and the little touch of unknown for the oral. So he really asked us not to give everything because he wanted to keep a touch of unexpected for the oral. It's his style, he's like that, you know, he likes to kind of, so it was his decision to really try to make it a little different from the press conference to the oral, because based on our rules, you were not embargoed, so you were able to communicate what he would have been told, telling at the press conference, you would have been allowed to tell it around. And he didn't want his kind of effect, surprise effect, to be changed. That's his style. It's really a question of the style of the presenter. So you bring us to a very important point here. When we leave this meeting here, we'll have to rediscuss a little bit the story of the embargoes, how to make the news how to make sure that you will always be exposed at the press conference to the whole set of data. When I say that, is meaning how much can you still be embargoed at that time? That might be fine. Still allowing the presenter to create the surprise effect at the session. There was some year, I'm sure you remember, where the embargo was lifted at the time of the presentation. So of course it was a bit more difficult for you because for some hours you couldn't say anything, but you had all the data in your hands, and when we were coming at the presentation, the embargo was lifted and the presenter was sure it was the first time anyone was seeing the data. And in terms of excitement, in terms of suspense, it was better. For example, Pacific, I received 20 emails from colleagues telling, is it normal that we have the New England Journal in our mailbox in the morning, and when we come to the presidential, I mean, we even know the little details stories of the side effects. It just cuts a little bit, the presenter who. So that's something we must discuss. And it's very good you bring this comment, because by having this embargo lifted, the risk is that we manipulate a little bit the communication in order to be sure that we can still make the excitement. And it's not good, because the excitement should come really by having probably you knowing everything, being prepared to announce, but to the public, the news should come in a glimpse during the presidential. So that's what I would favor, but we will have a democratic discussion in the group, but that's what I would favor. You understand more or less what?
Well, I do, but I didn't think it helped that Professor Scudia criticised the other study on its side. You can't fault that criticism, but I think there are particular issues there that meant that you could say that it's misreported.
Yeah. I can understand. I was not at the press conference, so I cannot see the nuance, but I can really understand. This is more about a type of communication, I guess. Sorry. But this is a format we'll have to discuss, and we'll be happy to have you in the loop. Tough in times. Yeah. Well, the data, the abstract did have all the data apart from OS, of course, which came 48 hours before. And then yeah. Any other question?
Are there any other studies?
Sorry, do you need this?
That might not feature here that you would consider, on the sort of borderline practice changing? The MAPS-2 study seemed to me is quite interesting, because I don't know. I don't think a large randomized phase 3 study is likely to be conducted in mesothelioma, so maybe that's the best data we may get.
Well, yes and no. The MAPS study is very interesting because it's again a proof of MAPS is a mesothelioma. It's not a comparative trial, but a phase 2 trial with one arm of nivolumab, one arm of ipi-nivo in refractory platinum pretreated mesothelioma. And what it shows is activity of immunotherapy. So there's a nice activity, and the survival curve was suggesting, even if we shouldn't really compare, that ipi-nivo gives rise to a kind of a longer survival than nivo only. This, by the way, should still be proven by a real comparative trial. But meaning immunotherapy works in that setting, of course, leading to FDA fast track. So FDA has NCCN endorsement and FDA fast track very soon. So NCCN has already endorsed ipi-nivo as being a standard in mesothelioma, which is NCCN guidelines. But well, first of all, we learned that mesothelioma is an immunosensitive disease, which is good because it was not really obvious until now. Second, will we have trials? Yes, there are. At least 4 big randomized trials in mesothelioma. There are 3 in the second-line setting and 1 very big in the front-line setting, combining chemo plus immuno comparing chemo to ipi-nivo. The Checkmate 743, if I'm right. So this trial is actively recruiting and will give us the answer for frontline, which is very courageous. And the other 3 trials compares the absence of standard of care in second-line mesothelioma. There's no really standard because no trial was performed to tell you what chemo to do there. You can do vinorelbine or gemcitabine, but there's no trial to support it. So there are many trials comparing best treatment, second-line treatment, as compared to pembrolizumab, for example. It's called the PEARLS trial, and another one with atezolizumab. So there will be trials in mesothelioma. It will take a little time because to do a mesothelioma trial, you need to open 100 sites globally and try to focus on Belgium, UK, some Eastern countries, because the prevalence of mesothelioma is very variable over sites and in the geography, but this will happen. What to do until now? It's difficult because this MAPS-2 really creates the certainty that immunotherapy is an option in these patients and is probably better than any kind of non-documented second-line chemotherapy. But how to get access to that? And this is a step I don't like because it's going to be very imbalanced across countries according to how you can have access to out-pocket potential paid drugs, or some compassionate programs, some off-label. So every country will be different in how they can give access. And this is not very good, and that's what we will have to deal with for some time. But this is not a context where we should be very happy, with which we should be very happy in terms of accessibility. But it's an interesting trial.
Okay. Well, if I may make, I guess, one more observation since we're having an interaction. The Stampede study, I thought, actually probably merited inclusion in your list, and it seemed to me, well, a shame, really, that there was a press release on it, so it was included in that, but not in the press programme, and yet that, to me, was very practice-changing, and I think it's also important that that's from a collaborative group, you know, and it doesn't have the sort of the PR effort of a huge multinationals behind it, and yet that...
Which study?
The Stampede study that compared
Stampede,
docetaxel with abiraterone in the hormone-responsive prostate cancer. You know, anyway.
Yeah, it was. We made a press release. Huh?
Yeah, there was a press release. Yes.
Yeah, yeah, and it was already presented once also before.
Well, at ESCO, yes,
ESCO,
but that was the comparison between the two agents that were separately shown to be highly advantageous.
Take a. It's very interesting, yeah. Yeah.
Sorry, do you need this?
Give you the microphone now. You ran, you recovered.
Okay. Yeah. What's the question? Okay.
Some general conclusion.
Oh, some general conclusion. Getting old in this field, I have been in this field for, at this point, 30 years. And getting old is always difficult to be really, to have emotional reaction to the presentation. And you get an emotional reaction whenever the delta and the quality of the presentation and of the study is such that is kind of unprecedented. What do I mean by unprecedented? Up until 4 years ago, we were used to seeing a hazard ratio of 0.8, 0.85, and sometimes I even got irritated to see these huge efforts being set up to demonstrate the difference, that when I go to the patient, I don't feel like emphasizing that enough. I perceive a real change in the rate oncology is moving ahead. And there is a scientific background in this statement on the number of studies where the hazard ratio reflecting a very substantial advancement is below 0.65. So again, I remember at ASCO 15 years ago when the first study on trastuzumab was presented. The delta was such that people were so thrilled. I remember people crying in one of the front rows about this impact. The same emotion I got at several sessions here. And I think it makes a lot of sense. Again, for the first time, well, I already said this at the beginning, but this is the main theme, at least at both emotional level as well as at the practical level. This is the main theme of this Congress, that you go back home saying, well, be optimistic because whatever we gain will give us more time, so that in little time you may expect a very substantial advancement. And this can be the message to our patients. And that is unprecedented to me. Sometimes we used to say that in a sort of compassionate way, that is, oh, don't despair. That was not entirely honest, because deep inside I didn't feel like in the next year or two major advancements were made. Whereas now I can use the word major by meaning 0.65 hazard ratio, meaning 4, 8, 12 months gain, which are very substantial gains in median survival. So again, there is a shift in the pace of progress. Some diseases are running very fast. Some others are still on the starting blocks. But the hope is that these will accelerate anyway, because the minority is on the starting block. Don't know if that makes sense, but that's the general feeling.
Sorry, I have to go because I'm chairing a session in 3 minutes. So it's just
Thank you.
next door, so I do have to run. Okay, thanks.
Bye-bye. Any other question? Any other comments? Yes, please.
Rosalia Rutter, Austria. I don't want to burst the bubble here, but we have been told by your press release that we're reporting a lot about the good news and not so much about the bad news. Would you care to tell us what your biggest disappointments are and where you think there should be, or concepts that didn't work out very well that you have been aware of right now?
Yeah, if you take pancreatic cancer or even colorectal cancer, those two diseases are kind of the starting blocks. We did not have very many advancements. We did not have hot stuff coming up in those two areas, for example. Although the colorectal area had a very important session yesterday that defined for the first time the new guidelines how to treat patients in the adjuvant setting. Now that was not an advancement because we are not increasing the chances of cure for these patients, but we are decreasing substantially the toxicity that these patients have to suffer by reaching the conclusion that only 3 months of chemo, oxaliplatin-based chemo, is enough. And actually, Tim Mohm from Oxford highlighted the saving that will lead to, has been calculated for Europe to be €500 million for just shifting from 6 months old type chemo to 3 months new type chemo. For pancreatic cancer, very little movement. Why is that? Because that's a sort of immune desert type of disease. But again, by analogy with what has happened, mesothelioma is a fantastic example that is moving. So again, I cannot tell my patients that there are breakthrough in these areas, except for colorectal, fine-tuning on the old stuff, okay? But I'm pretty sure that I can nevertheless say, maybe this will start.
I think we will have to close this press conference in order to let our colleagues go to their next commitments. So thanks a lot. And if you need anything, you can still go to the colleagues. We should be around for some more hours. And thanks a lot for the attention and participation into this press conference and the meeting. Have a safe trip back.